So under normal conditions, EGFR is in an auto-inhibited state, and it's only when it's needed that it's upregulated. But when you have cancers that there is either a mutation in the EGFR or an overexpression, what you see is a dysregulation of normal cellular processes. So you get overexpression or switching on of prosurvival or antiapoptotic responses.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about the EGFR inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which will include a link in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation, also linked in the episode notes. Thanks for joining us today, Mo.
Thank you, Lenise. Always happy to talk about drug therapy and cancer.
And you do it so well. Let's start with giving us a brief overview on the history of EGFR inhibitors in the field of oncology.
Certainly. I really love talking about the history of drugs as they have been developed in cancer, especially for a class such as the EGFR inhibitors that I've seen come to be developed and then evolve in practice. The history of EGFR inhibitors should start with a discussion about the identification of EGFR receptors and the impact of mutations on those receptors on cancer, and then the subsequent development of drugs that inhibit or target EGFR. But that's really not the story, and it's kind of interesting. The initial trial of an oral EGFR inhibitor was in 1998, and it was for gefitinib. And I remember really vividly because it was a phase 1 study. And what was shown is that there were a couple of patients in that study that had non-small cell lung cancer that had nice objective partial responses. In fact, I remember being at a conference and having someone talk about how well one of the patients did on that study. And I was intrigued. That led to the phase 2 studies in non-small cell lung cancer. And again, there were some great responses, and they were in patients, most often in females, never smokers, or individuals of Asian origin. But it wasn't until 2004 that the mutations affecting the tyrosine kinase domain of epidermal growth factor receptor was linked to the responses that were seen in gefitinib. And that's when we really started to understand the way that this was targeting certain patients' cancers. So that led to the phase 3 study. People may remember the IPAS study that demonstrated that when patients had an activating mutation of EGFR, that was a really good biomarker that selected out patients that would respond to therapy. Since that time, we have seen an explosion of EGFR inhibitors on the market in terms of not only number of agents, type of agents, but also where they fit in practice. It's a real interesting story, and it's one that probably we wouldn't see today because we're a little bit more find the target, create something that targets it, versus this was a little bit different.
That is so fascinating. I had no idea about that history. What are some mechanism of action that the EGFR inhibitors are associated with?
So the EGFR inhibitors, I often think of them as like two groups, and that is those that are antibodies and those that are small molecules that are called tyrosine kinase inhibitors. So let's talk about how that works. So EGFR belongs to a family of receptor tyrosine kinase. So EGFR, also called HER1, is part of the family of HER2, HER3, HER4. So these receptor tyrosine kinases are surface receptors. And when they are stimulated by the ligand, there's phosphorylation and downstream signaling to the cell to do different things. So under normal conditions, EGFR is in an auto-inhibited state, and it's only when it's needed that it's upregulated. But when you have cancers that there is either a mutation in the EGFR or an overexpression, what you see is a dysregulation of normal cellular processes. So you get overexpression or switching on of prosurvival or antiapoptotic responses. Basically, what that means is that it turns on proliferation, motility, angiogenesis, and invasiveness of those cells. So when you think of the mechanism, the tyrosine kinase, they prevent autophosphorylation, which is important in that downstream signaling. The antibodies to EGFR, those prevent the ligand from binding to the receptor. So overall, these drugs work by turning off the overexpression of that EGFR and the impact of how cells proliferate.
You mentioned different subclasses of these inhibitors. Can you highlight some examples of some of the newer agents?
In my mind, I think of the EGFR tyrosine kinase inhibitors that I think most people are familiar with, mainly for non-small cell lung cancer, but it's used in other diseases. And then there's the monoclonal antibodies. And then there's a new group that is the bispecific. So the EGFR tyrosine kinase inhibitors, the first generation, are things like gefitinib, which I mentioned, or erlotinib. The second generation, these were developed, they are bound irreversibly within the cell. So thought that would have more activity. And then the third generation, which I think is the one that most of us are familiar with in practice now, osimertinib, it has some broader activity on different mutations. Plus, it has increased CNS penetration. So that's when you're thinking of the EGFR TKIs, they talk about them in terms of generation. I also think of, because I work in head and neck cancer, I think of the EGFR monoclonal antibodies, and that's agents like cetuximab or panitumumab that's used in colon cancer. And these monoclonal antibodies are used in those cancers where there's typically overexpression of EGFR. So head and neck cancer, as I mentioned, that's where I see cetuximab. The new player on the market is the bispecific. So when people think of bispecifics, they think of bispecific that are T-cell engagers. This is not. This was a bispecific that was developed to hit two different targets. The one target is EGFR. The second target was MET, M-E-T. And the reason MET was targeted is because when you have patients who are on EGFR tyrosine kinase inhibitors, they do so well. But over time, resistance develops. And one of the mechanisms that are thought to be important for resistance is that MET pathway. So it was development of a bispecific antibody that hits two different targets, EGFR and MET, hoping that you would get less resistance. The drug was actually marketed because it was also shown to hit the exon 20 in certain mutations on EGFR. And we didn't at that time have other drugs that hit that mutation. So that was actually what the drug was approved for. But I always think it's really interesting because it also does hit MET. And I keep wondering if we're going to see different uses over time with additional study.
Things are so much more complex than the chemotherapy that I gave as a young nurse. One of the things that we always think about when we're caring for our patients are how we can manage toxicities and adverse events. Can you talk about what some of the common toxicities and events can be with these inhibitors, both with an individual drug as well as the subclasses?
When you think of epidermal growth factor inhibitors, you think of epidermis. So you think of changes that can happen to epidermal tissues. So rash is probably one of the most common. And even though it's common, it's something that can be really problematic to patients. That's a major toxicity that you can see. It's often in the face, upper trunk, like so shoulders, chest, and upper back. Just, face, just where people want to have a rash. So that's one of the big ones. You can see nail changes. You can see hair changes. I always think of the hair changes to like the eyelashes because sometimes it's a more coarse type of hair. And so sometimes the eyelash can grow, can turn the other way and can scratch the cornea. So you got to really make sure patients realize that if they're having any kind of issue with that, to give you a call. Mucositis, again, thinking of like epidermis. Diarrhea can be an issue, and not as commonly, but something that's important is interstitial lung disease. And there's some suggestion that this is more of a problem. Even though it's relatively rare, it's a common in people that have been smokers or have had pre-existing lung fibrosis because it's impaired healing to the lung. Because one of the things epidermal growth factor normally does is help repair tissue. So if you're blocking that, you're not getting that repair. Now, for the monoclonal antibodies, you have what you think of as your classical monoclonal antibody infusion reactions. They are actually more severe in some cases. And then that cetuximab has that first dose infusion reaction that has been associated with prior exposures to things like mouse antigens. And then also a decrease in magnesium. And the reason I bring this up is if you don't use cetuximab or panitumumab very often, you may not kind of hone in on this, but it's really challenging to help make sure people's magnesium stay up, especially when you're dealing with elderly patients with comorbidities of heart, with heart conditions. They need that magnesium to be at normal levels.
Exactly. And then you have the side effects that go along with trying to replace magnesium all the time.
Exactly. Because diarrhea, just what you want, right?
Exactly. We're causing diarrhea and then we're trying to treat the side effect and then we're causing more diarrhea. Perfect. Speaking of these, what are some of the pharmacology related strategies that can be used to prevent or manage those toxicities?
So one of the things that I think is really important is educating patients the things that they can do to help minimize some of these toxicities. So the rash is an acneiform rash that it really does look like, I was going to say me in high school, but it does look like the acne. And so people think if you dry it out, that's going to be good. Sun can actually make it so much worse. So telling people to make sure they do sun protection is important. I once had a patient who came back from Florida and you could tell exactly where he had not had good sun protection, where he had this rash. Hydration, moisturizers. And so one of the tricks I learned from somebody who I worked with in dermatology is that moisturizers that are in tubs are more effective than ones that are in like squeeze bottles. They tend to be a little bit more expensive as well. So I give people a couple of options that they can pick up, the ones that are most that they like best, but really using good moisturization even before patients have that rash. And then if you need to, you can go to things like topical steroids, doxycycline. Doxycycline is an antibiotic, but it has anti-inflammatory effects, as any woman who's taken it for UTI knows, because it decreases the pain almost immediately. That's been used. And then sometimes you need to do dose modifications. So that's for the acne. You can take that to nail protection as well, moisturizing, protecting the nail from a lot of trauma, things that we say with a lot of the different agents that cause damage to the nails. Diarrhea, making sure people do the things that we educate people for diarrhea. If they have diarrhea, they know what to take. If you're going to give loperamide, making sure they have it available. They know the dose to take. They know to call, keep fluids up, those type of things. So a lot of education. And then what I like is for patients to call if they have problems, because then you can fine tune things that the patients may not have remembered when you did initial counseling.
Exactly. They hear a lot when they get their first education and then they call 2 weeks later and they're like, I don't remember ever hearing for all the right reasons. What are some administration considerations that nurses should keep in mind when administering EGFR inhibitors?
So when you're looking at the monoclonal antibodies, the cetuximab and the panitumumab, and definitely the amivantamab, which is the bispecific, first dose reactions are very common. So I do a lot of education for patients that if they feel anything during their infusion, they tell the nurse immediately. Like they don't wait around to see if it's going to be bad, because these can be really significant reactions. Doesn't mean that they can't get subsequent doses, but they need to be managed. And I think that having people that have expertise in these drugs is really helpful. It's an education thing, and it's having patients kind of be aware of what can happen. I don't try to overscare them, but those are things that I consider. As I mentioned, the cetuximab and the panitumumab, to really make sure about the magnesium. I'm kind of a advocate for magnesiums a little above what some people think are adequate. I like magnesiums up close to 2, especially in people with any kind of heart condition. Again, learned that from a colleague once to keep that magnesium up. And that's a little bit of a challenge. So that's another thing to keep in mind. In terms of administration of the oral drugs, we have all those things that we always talk about with oral drugs. Drug-drug interaction, not only when you start therapy, but throughout therapy. Toxicity management, when to hold, when to call, when to institute some of those strategies we recommend. So those are the things I would think about for both administering the oral agents as well as the monoclonal antibodies or the bispecific.
You talked a lot about some of the patient education that you've done around skincare and about fluids and that sort of thing. What are some other education points that you would want to communicate to both patients and their caregivers?
I like to tell people where they can find information. Like I hand information out, and somebody at University of Cincinnati, before I got there, put together a really nice patient handout, like the skin toxicities. Somebody else has a nice handout about how to manage diarrhea in patients with cancer that are getting certain treatments. Having those available for people, because just like we talked about, you said it, I see it every day. I will say something so clearly, I think, to a patient, and they will never remember hearing it. So having those things handed out are really good. And then letting them know where they may be able to go to get information online that you think is good information. I think those are all important things to communicate.
I think it's a really good idea to point out the trusted sites that you have, because it gives them permission to look, but also lets them know that there's places they may not go that are as trusted or may not be giving them accurate information. So if we can, along with our education that we're providing them about their care, if we can provide them some education about how they can get the right information, is always going to be helpful.
I think so too. I think people are going to look. Some people are not going to look at all. And then other people are going to look the minute they go home. And so like helping them understand what they're reading, I think can be very helpful.
Exactly. How can pharmacists and oncology nurses collaborate to manage these adverse events and toxicities, provide the patient education, and serve as a trusted source of information?
The things that I have seen work best is the development of a consistent approach that people use. Doesn't mean you can't try new things, doesn't mean you can't modify it, but then they're getting one message. And I think that's important for patients. I think they love when they hear something from the physician or the provider, from the pharmacy part of the team, the nursing part of the team. I think they like that consistency. So I am all in for me doing education as well as everybody else. I like that. And I like when you develop strategies that they can read simplified information for, well, I got to tell you, people always say to me, what lotion do you recommend? So I was really glad that on that sheet of paper that talks about skin management, it gives a list of different lotions that you can use. Those are things I think that are really helpful. The other thing is, I can't say this strongly enough. When something occurs, putting a note in the chart is great. Love it. I go back to them. But talking to the team when things happen, so everybody is on board. I think we have gotten a little away from that with how easy it is to put a quick note in your electronic health record, which someone may not see for 3 weeks if then. So I think coordinating what's going on, like I saw Miss Jones today, she's starting to get this rash. I think you might keep an eye on it. She may need something else besides what she's using. I think that's a great strategy.
I think that's perfect. And having those conversations, because you want the provider to know those events are happening or that something is starting to brew a little bit before they start writing that next round of chemo orders. So you mentioned the history and how we got to this point of these medications and the evolution of how we've gotten more. What does the future look like for these agents and their role in the landscape of cancer care?
I look to what has occurred over the last, what has it been, 10, 20 years. And I think it gives us an idea where they're going to go. Understanding the type of mutation. There are different type of EGFR mutations. There is a common exon 19 deletion, but then we learned over time there's that acquired exon T790 mutation. And different drugs work with different mutations. So I think more and more we're seeing better understanding of the acquired mutations that occur. The other thing that I see with these agents is seeing them combined with chemotherapy. For a long time, it was these drugs were used as the single approach to someone with non-small cell lung cancer who had an EGFR mutation, and they did well. But I think we're starting to see that because resistance does develop, that there may be roles for combination with chemotherapy, and you're seeing that in terms of drug approval. You're also seeing these drugs being placed earlier in therapy, not in just patients that have metastatic disease, but an adjuvant therapy. I think that's going to continue to evolve as the studies show there's benefit there. Now, the thing that I think we're going to see in terms of new drugs, we're going to see more of those third generations drugs like we see with osimertinib, drugs that penetrate in the CNS, something that's really important, drugs that work on different types of mutations. I think that's coming down the pipe. The other thing that we're seeing, and I think we saw it a little bit with amivantamab, is these bispecifics, like to target EGFR and target something else. I think that's going to continue to evolve. Antibody drug conjugates, taking a monoclonal antibody that targets EGFR and hooking on a chemotherapy agent. I think those are definitely in trial right now. So that's something else I think that's going to occur. This is not a uncommon mutation, and it's certainly important in diseases, even where it's not so much a mutation, but overexpression. So I think we're going to see the therapy continue to get better and more specific to the needs of patients.
This has been fascinating and very enlightening for me. I've been away from the bedside for just a little bit, so thinking about all the evolution of these things has been great to hear. I have just a few more questions for you. What are some hidden or implicit biases that healthcare professionals may have about EGFR inhibitors or how it could impact their management of a patient receiving one of these medications?
I think if you don't use these drugs very often, I think you remember when they first came out and how challenging the toxicities were, and that you have that bias that these are very toxic drugs. And that I think with the evolution of drug therapy, better understanding how to manage patients, that they are not what they were in 1998 or 2004. And so that we have agents that can be very beneficial. Even the toxicities with amivantamab, I mean, there's strategies to use that drug successfully. So I think realizing that initial experience does not really tell you what's going to happen long term.
What are some common misconceptions about the EGFR inhibitors?
I think that people that don't work in clinics, say with non-small cell lung cancer, they think of these as a group and don't realize the uniqueness of specific agents, what mutations that they hit, the fact that those that penetrate into the CNS, the drug interactions that are specific for certain agents. So I think that's one of the common misconceptions.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think the thing that I have to continue to teach myself to look into is all of the different type of mutations of epidermal growth factor receptor gene and how that impacts patients. And so I think that is something that I just think is important to talk about. When a new drug comes out that is specific, I'll just take the example of EGFR exon 20 insertion. So we heard a lot about that mutation when there were new drugs, but you don't see that stuff all pulled together for the new practitioner. Like, how do I think of these agents? And I'm going to give credit to ONS here because I think ONS has done a great service for practitioners in providing resources about the specifics on their educational website.
What additional training or education do oncology nurses need to stay current on this topic?
The education is because it evolves so rapidly, is to realize that what you know, if it's from a year ago, may not be the full picture. And so again, I'm going to call out ONS for the phenomenal resource on Genomics and Precision Oncology Learning Library to help providers learn. And that is updated and it is readily available. I think it is phenomenal. And I think it helps people build on their basic understanding of any of these types of therapy, including EGFR inhibitors. Those are things I think are important. The other thing, this is going to sound, I can't even believe I'm saying this. I was at a conference in Indiana, I think it was in the summer, and there was a practitioner, actually someone who I knew well, who works in pharmacogenomics. So I went to the talk because I wanted to hear him, to support him. It was phenomenal. It was phenomenal because it went from basics up to current. So I think that there are so many opportunities to go sit and listen and learn from people at different types of, whether it be Congress or your local ONS meeting, which this was a ONS meeting in Indiana. I think there are lots of opportunities and people are making sure that information for practitioners is being presented to help us do better taking care of these patients.
I think that sounds like an excellent thing to do, is making sure you're staying current. Thank you for referencing ONS's materials, because I think that they are, our clinical team does a lot of work making sure that we have these available. One of the things I remember most from my pharmacology class in grad school was that I should never be afraid to walk away from a patient saying, I need to go look something up. And I think what you've talked about in this podcast is really about how things have evolved and how what you knew a year ago is no longer current information. And so you should always be willing and quick to go look something up to get more information on the topic. To that point, what are some additional resources that patients and providers can go to learn more?
I'm going to call out something I found recently when I was updating a lecture. It was a series, it was published in 2022 from Seminars of Cancer Biology. Not one of those journals that you read at the dentist. But the key thing with this, it was an overview of strategies for targeting cellular signaling pathways. The EGFR was one of them, which is how I came across it. I actually ended up printing out all of them because they were just fascinating. So there are nice review articles in the literature, and I'll send this reference if you want to post it. The other thing is, I will say ONS, I think that's some of the best resources that you can get to fast. The thing about the ONS resource is it gives you the information, but it also explains it. And I like that. So then you can, when you look using other resources, so people use Lexicom or other resources in their institution, sometimes it's hard to understand where it fits in therapy because you're just reading about a drug. So that's why I like to couple it with something like you see in the ONS website. And I'm not just saying that because this is ONS. I honestly think it's a phenomenal resource.
Thank you. Mo, it's been great talking with you. I always enjoy being able to learn more, listening to you and hear about things from a different angle. Do you have any final comments for us?
I just think that the story of EGFR is amazing. It shows us how in the past, we looked to see if drugs worked and then try to figure out how. Where now we're designing drugs because we're learning more about the biology. I think those things will continue to happen. By understanding the role of EGFR in different diseases, we focus a lot on non-small cell lung cancer. EGFR mutations and overexpression are found in other cancers, such as bladder cancer. So I think there's still a lot more to learn, but I hope this gives kind of the foundation needed to see how that's going to impact.
Thank you so much. And I hope you have a great rest of your day.
Thank you. Thanks for this opportunity. I always enjoyed talking to you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.